Hi, I'm Lucy Alvarez. I'm interested in becoming a registered respiratory therapist. Today I've been given permission to shadow and lead RT at Volunteer Medical Center, and I'm really excited.
Hi, Lucy. It's a pleasure to meet you. My name is Dee Dee Stover. I am the lead RT you'll be shadowing with today. How are you doing?
Great.
That's awesome. Well, I am very happy to have you. I do want to let you know that I have just looked at one of our patients' information. We're going to take care of a specific lady today. And our pulmonologist gave me an updated order. She might be discharged today, so that's really good for her. And before we, let her leave and go home and take care of herself, you'll be able to assess her and things like that. So I do want to let you know that I have spoke with HR. I've confirmed that you've had your HIPAA training, that you're cleared and good to go for your job shadow, which is great. And I know you already know, not to post anything on Facebook. What happens in the hospital here and our care stays here, and we want our patients to feel safe and their information to be safe. So what we'll be doing today is a little bit of patient assessment and reviewing some medical records of our patient. So I want you to feel very comfortable that, I won't let you just get in there and feel lost. We're going to go through things step by step, and hopefully you'll learn quite a bit today. Are you excited?
Yes, I am.
That's awesome. Well, let's get started. The first thing I do before I even assess my patient is I look at their electronic medical record. So as I said, in our patient's electronic medical record, as you can see here, there are certain things that we're looking for. The first thing that I look for is their information that tells me a little bit about their admission process. A person's admission process can tell me a lot about why they came to the hospital and what might be our indications for how we treat them. So we actually have a systematic approach that we look for. It's called SOAP. So SOAP, not what you're going to wash yourself with, it's actually an acronym. It stands for subjective, objective, assessment, and plan. This helps us understand what we're looking for in terms of the information we're getting from our patient and the information and response that we give to our patient. So that first portion, subjective, really comes down to what is the patient telling me about how she feels. If she tells me something about a symptom, that would indicate to me that she is expressing what she knows about what's happening to her. It may not be what's actually happening, but it's her response to the pain, to the disease process, whatever. I feel this. So that second portion, that objective, is what we as the practitioners can observe and measure, see, feel, hear, smell even from our patient. It's something that regardless of how she feels, this is what her body, her vital signs, her temperature, her blood pressure, her heart rate, that's what it's telling us. We're getting measurable numbers, data, concrete information that is repeatable and that we're able to use to assess from assessing our patient. Now that third letter, is the assessment. That's the portion where we are determining the diagnosis and the condition that our patient is in. This will be the therapeutic procedures we go through in terms of making sure that our patient is able to hopefully have that fourth part, the plan, have a very good outcome from their plan. So that plan will end up being how we treat our patient. This will include all of our goals, our protocols as therapists. We have certain protocols that we go by that help us address our patient's needs. So SOAP for us is just kind of our way of going through and systematically addressing our patient's concern. And we find that information right here in this first portion. Can you see okay? Okay. In this first portion of their admission. So when they first get admitted to the hospital, someone begins to assess, okay, how are you feeling? They start taking vital signs, they get triaged, and at a certain period we begin assessments for that patient, further diagnostics to see what's going on. And then a pulmonologist or physician and myself and whoever's on that team will begin making a plan. Okay, so our patient today, like I mentioned before, is a nice lady. She has had several admissions here at the hospital. Unfortunately for her, She has had a COPD exacerbation last week, and that has caused her to still be here today. Hopefully discharged, right? So, for Miss Tubbs, that's her name. She's a 54-year-old African American female. She's smoked before. She's had a rough time with COPD, and she's the one we're going to be taking care of today. So, before we go on, I want you to see exactly what a soap looks like, and specifically what it looks like for our patient. So this is what exactly Mrs. Tubbs said. She said that she felt like, in her subjective point of view, that she couldn't breathe. She was being smothered, kind of like when an elephant would sit on your chest. It's just hard to get a breath. And our objective portion right here shows a lot of detail. So I know it's a lot of information. Try to keep up with me if you can. We took our eyes and our ears and our hands and we assessed our patient and observed objectively that she had a heart rate of 138, that's tachycardic, very fast. A respiratory rate of 28, again, very fast. Blood pressure was elevated to 148 over 98. Her temperature was elevated 100 plus degrees. And she was using her accessory muscles. I know you've taken A&P, anatomy and physiology, so you're aware of those muscles we use to breathe. She was working very hard to breathe. She had hyperresonant percussion notes. That means that when we tapped on her body, we could hear the air louder in her lungs than we probably should have. She also had diminished breath sounds. That means when we're listening for that airflow, it's very hard to hear them. They're very quiet or soft or muffled. And she also had some end expiratory wheezes. When she was breathing out, she was wheezing. You can hear that kind of that odd sound where it sounds like she's struggling to get that air out, because she is. Overall, she looked very catechotic. She had increased AP diameter, that's anterior posterior. So when looking at her chest, it looks kind of rounded. You know how we stand up nice and tall, our chest kind of narrows out with our belly button, and it's kind of a little wider at our shoulders. Hers is more circular all around. All that air kind of it's stuffed in there. You can think of it that way. She had no digital clubbing and no pedal edema, which is good. That means she doesn't have as much fluid overload. Her chest x-ray, which you can see right here, it showed these bilateral lower lung infiltrates. That means there are these portions of her lungs where there are things that should not be there. These things are causing her to have difficulty breathing, and it's often built up mucus, secretions, things just pooling in the bottom of her lungs. Up here you'll see this hyperinflation, and down here, do you recognize this organ? Yeah, this is the hemidiaphragm. So this is going to be that part of her anatomy that helps her to take a big breath in and out, and it's flattened out because there's so much air pressing down on it. We'll also look at some of her PFT. That's her pulmonary function testing. We want to see how well her lungs can move air. And it showed that she had a decreased FEV1 and FVC ratio, and it was 55% of her predicted. If 100% is the best, that's like half. That's not too great. And she also had a decreased FEV1. It was 35% of her predicted. Think how much worse that is than 55. Okay? So she's breathing out of the air. We took an arterial blood gas. I don't know if you're aware of that. When most nurses come by in a hospital and take blood, they're getting it from your veins. But an arterial blood gas is actually taken from your arteries. You can take it from the radial wrist, right here, or brachially in your arm, and also through your femoral artery in your leg. But we often don't have to go that far. We're able to usually get it from the wrist. And you see right here through this data, she had a blood pH of 726, CO2 of 78, bicarb of 39, and oxygenation of only 41. So those are not super great numbers. It actually shows us that her body is holding on to a lot of CO2 that we breathe out normally, and that she's not oxygenating very well. You know, your tissues need oxygen, right? So when we assessed our patient, we first noticed that she had bronchospasm. I actually have a picture of that to demonstrate here. So this is your trachea. Think of it being right here on your body, okay? You have bronchioles. These are the branches of your lungs that are going to help direct that airflow into those smaller portions of your lungs that make it look pink and fluffy. So these areas are constricting. They're kind of squeezing down and creating a smaller lumen and making it harder for her to breathe, okay? I'm gonna set that right there so you can kind of use that as a reference. And she also had pulmonary hyperinflation. Remember we said that air was just stacking up and staying in her lungs? That's diagnostically what it's called. She also had acute ventilatory failure on top of chronic ventilatory failure. This means that she normally has poor ventilation, and then she had an incident that caused her to have even worse ventilation on top of her normal poor ventilation.
Okay.
And of course, moderate to severe hypoxemia. You can't breathe in and out, you're not getting oxygen in, that's a really tough situation, and your body will know it and show it too. And of course, last is our plan. This is the part that you're going to be able to participate in today. And of course, you audience, you're welcome to take notes and get involved too if you can. Just think about some of the things we're talking about. And in the plan for respiratory therapists, we are very concerned with oxygenation, ventilation, those life functions. So a lot of our assessment is always going to be to see if our patient is doing those top two, ventilation and oxygenation. So we have protocols for her ventilator management, her oxygen therapy, and her aerosol therapy. Because we're going to talk a little bit about it. There are some drugs that can help her open up those lumens that we talked about in her bronchioles. There are also some therapies that we're going to do to assess her ventilator, make sure she's getting the best care. And we also want to be able to assess her oxygen. That's very important. Tissues tend to die in the body without oxygen. So we're going to actually assess her for that. And today, because she is possibly being discharged, we're going to initiate something very special called BiPAP, or non-invasive positive pressure ventilation. And here's her settings right here. Can you read these for me? I want you to be able to see what we're going to do today.
IPAP of 10.
Good.
EPAP of 5. And we're going to set her F102 to 24%.
You know what? That's pretty great. I just want to let you know, because I did go over terminology with you, we call this IPAP.
Okay.
That's the pressure when you're inhaling or inspiring, and then EPAP is when you're exhaling.
Okay.
And then that little word right there is just FiO2. It's how much oxygen you're getting, that fraction of inspired air, or excuse me, of inspired oxygen, and it's just 24%. Do you remember how much oxygen's in room air?
Not sure.
It's 21%. So we're
Okay.
just giving her a little extra boost of oxygen there. So we're going to try to titrate her FiO2 so that when we look at her SpO2, that is the saturation in her blood, that it reads somewhere between 85 and 88%. And I know you've heard before you want really high SpO2, like 94 and higher, right? Well, so I'm sure you've heard that most times we want to keep a patient's SpO2 between 94 and 100%, right? Well, for COPD patients, we want that number to be a little lower. They have a different way that their body responds to oxygen. So we're actually going to keep it between 85 and 88%. So she's actually going to get this drug here called albuterol. 0.5 milliliters in 3 milliliters normal saline. That's like a solution we put it in so it can be aerosolized. And we're also going to get a sputum sample from her, have her cough up some mucus, and do a culture and sensitivity test. So, the patient appeared to be in about a moderate amount of distress. She was working hard to breathe. She was feeling very uncomfortable. And when she arrived, they assessed her vitals. They actually put her on that BiPAP machine for 30 minutes. And I'll explain a little bit more about how BiPAP works later. But I want you to look here at these PFT results she had earlier this month. This was before she came in for her exacerbation. So an FVC, her predicted was 2.4 liters. Remember I said she had a very low number, she only had about 55%. It actually came out before her bronchodilator, which would open those bronchioles like we talked about to open these up, was only 2.8. After she got the bronchodilator, 2.76, not much change. The same is true for her FEV1. It also showed that she did not have much change. Her predicted was 1.92 liters. Before her bronchodilator, it was 1.6. After the fact, 1.64. No major change. And then her percent FEV1 over VC Predicted should have been 82%, but she only had 57
Mm.
before her bronchodilator and 59% after. So not much improvement. Obviously, that bronchodilator was not sufficient for what she needed. So we'll progress a little further into some of our patient care plan that will better address a little bit more of her special condition with COPD.
Okay.